We are going to go ahead and get started. Welcome, everyone. I am thrilled to welcome you all to the webinar this evening. We have an amazing turnout. We had just under 1,200 people registered, which is a lot. And a lot are here now and are logging in. And I'm going to do a little bit of housekeeping first before we get started. For those of you who don't know me, my name is Dr. Lauren Levine. I do these webinars on a regular basis. We're thrilled to be working with Golden Dent tonight in presenting Dr. Tim Kosinski. This is part 2 of the suture membrane tips for success. You do not need to have attended part 1 to know what's going on here. This isn't like if you decided to watch the first episode of Yellowstone in season 5 and you have no idea what's going on because you missed the first four seasons. This is not the case. That being true, on the invitation that was sent out, there was a link where you can download and watch that. And if you just go on YouTube, you look up Golden Dent, Golden Dental Solutions, you'll see right on their website, on their YouTube site, the full recording for part 1, which was done about a month or so. So like I said, I'm going to do a little bit of housekeeping here. I certainly commend you all for being here this evening, continuing your dental education. In the next few days, I want you to keep an eye out for a couple of things. First off, this webinar is being recorded. You will get a link to this webinar as well as the part 1 that I mentioned earlier. That usually goes out within a few days, so keep an eye on your inbox for that. So don't worry if you get distracted or can't make it to the end. It's all being recorded. During the webinar, Dr. Kosinski is going to show some of the systems and products that he uses in his practice, which are exclusive to Golden Dent. I want to thank them as always for their sponsorship. I've had the pleasure of knowing Kurt and their entire team for, God, it's got to be around 10 years now. They are the ones that are bringing in these amazing speakers. They're the ones that are helping to put together the content. They are also the ones that handle the CE. I get questions about this after every webinar. I'm going to try to mention it at least a few times this evening. The basic rule of thumb with CE is if you're here and you stay, you get the CE. There's nothing that you need to do. There is no registration, no quiz, no test. There's nothing that has to happen on your end. What happens afterwards is I send the list to Golden Dental. They go through it and they see when did you log in, when did you log out, and as long as you were there for the bulk of it. AGD PACE has certain requirements. I don't know exactly what the number is. It might be like 75% or 80% or whatever. But basically, if you're here now, if you're listening to me live and you wait to the end, you're for sure going to get it. With 1,200 people registered, that can take a little bit of time. So, I would say within about a week or so, give or take, keep an eye on your inbox. Check your junk folders as well. For some reason, some of these end up in people's spam, but it will go out. If you don't have it, say by middle of next week, by all means, shoot me an email and I'll be happy to follow up with them to see what's going on. So with that out of the way, I am thrilled to welcome back Tim Kosinski. Many of you have been on previous webinars where he has spoken. His resume is unbelievable, and the truth of the matter is, and I know I always make him laugh when I say this, but if I read through his entire resume, we literally wouldn't have any time for the presentation. So I'm going to give you kind of the Reader's Digest version of it. But he is an affiliated adjunct clinical professor at the University of Detroit Mercy School of Dentistry. He's on the editorial review board of Reality. Most of you know that. That's the information source for aesthetic dentistry. He's the past editor of the Michigan Academy of General Dentistry. He's currently the editor of the ADG journals, General Dentistry and AGD Impact. He was recently named editor of Implants Today, which is the implant publication of Dentistry Today. He's past president of the Michigan Academy of General Dentistry. Dr. Kosinski received his DDS from the University of Detroit Mercy Dental School and his mastership in biochemistry from Wayne State University School of Medicine. He's a diplomat of the American Board of Oral Implantology and Implant Dentistry, the International Congress of Oral Implantologists, and the American Society of Osseointegration. He's a fellow of the American Academy of Implant Dentistry, and he got his mastership in the Academy of General Dentistry. Tim has just received so many honors, including a fellowship in the American and International College of Dentists and the Academy of Dentistry International. Back in 2017, he received the Academy of Dentistry's International Humanitarian Award in recognition of significant contributions to the enhancement of the quality of life and the human condition. He's a member of OKU, the Pierre Fauchard Academy. Dr. Kosinski was the University of Detroit Mercy School of Dentistry's Alumni Association's Alumnus of the Year, and 3 times, 2009, 2014, and 2020, he received the Academy of General Dentistry's Lifelong Learning and Service Recognition. Dr. Kosinski has placed over 16,000 dental implants and published over 220 articles on the surgical and prosthetic phases of implant dentistry. And he was a contributor to the textbooks, such as Principles and Practices of Implant Dentistry, and back in 2010, Dental Implantation and Technology. So, Tim, we are thrilled to have you back and looking forward to part 2 of what was a great part 1 presentation.
Oh, thanks, Lauren. Yes, you do always make me laugh, and I hope everybody's staying warm out there. It's very cold here up in Michigan. So, yeah, we have a really nice attendance today, and I'm always a little bit taken back by that and humbled. And what we wanted to do, because we had so much positive feedback from part 1 of suture and membrane tips for success, that we decided, and thank you, Lauren and Kurt from Golden Den inviting me back, because I think we have some important things to share with dentists out there. You know, as you mentioned, Lauren, we do a lot of implants, and implant dentistry has certainly become a pinnacle part of many of our practices out there. And for those of you who are not involved in the surgical applications of implant dentistry, I strongly recommend that you do get involved. There's a lot of phenomenal training programs out there now that are going to make you very, very competent, efficient, and proficient in treating your patients. And as you know, your patients are coming to you asking for this unique procedure that we did. When I started as a young man, you know, implant dentistry was experimental. I heard that a lot, but now it's pretty mainstream. So I strongly recommend you get involved. And again, I appreciate y'all listening. I'm watching the numbers go up and up, Lauren. You know, something that's very, very important to me. I just lectured at Yankee Dental, and we had a sold out audience. And you know, it's always very interesting to see the experience levels that many of my colleagues or our colleagues have. And many of the techniques that we learned in dental school. Some of us became very proficient, and we have instruments and tools that allow us to practice a certain way. But again, time is money in your practice, and if you are involved in implant dentistry at whatever level, restorative or surgical, I think it's imperative that you learn how to graft. Grafting is a very, very important part of setting a foundation. If you're going to build a house, no matter where it is, you have to create a good foundation. And learning to create a foundation is as important as drilling a hole in hard tissue and threading in a spark plug into the bone. And then tissue management is equally as important. It's not only building the bone. I like to say, Lauren, that in today's environment, you know, we can teach dentists how to grow bone very predictably. We can grow facial plate. We can grow bone in sockets very predictably. But oftentimes our limiting factor is our patient's budget. The fear of the dentist sometimes can also be a limitation. So extracting teeth is important. We'll touch on that briefly. Grafting is very, very important. And again, as important as those 2 items is suturing techniques. So we must respect soft tissue. Lauren, being a periodontist, you know that. We must respect attached gingiva. We must have attached gingiva, a band of attached gingiva at least on the facial aspect of all our implants to maintain periodontal health and long-term stability and function of those dental implants. So that's what we want to spend the next 50 minutes with you. Then we'll have plenty of time for questions as you have. So let's just get right to it. Here's a view of northern Michigan, Lake Michigan, just a beautiful place to be. If any of you have never been to northern Michigan, I strongly recommend that you put it on your bucket list for possible visitation in the future. It's my therapy area. And you see a website on the lower left-hand area that says drkosinski.com, and that is not my office website. It's not a marketing website. Rather, it is an education website where I've included many of the cases, my publications, my YouTube videos. I think we have over 200 that you can review some of the things that we're going to very briefly touch on today in a little bit more detail. So briefly, Lauren, I always do this, learning objectives. Let's just learn some suturing techniques that will deliver predictable healing results. Healing is important to patient management, pain management. If we don't incise into mucosal tissue with our reflections, our patients really don't experience a lot of discomfort. It's when we incise into mucosal tissue, and many of us were taught to make vertical incisions to make a reflection or a flap. And once we cut into mucosal tissue, we get prostaglandin and histamine release, and those patients are uncomfortable. So let's learn some suturing techniques to minimize patient discomfort. And we'll talk about proper reflection or flap design for better aesthetics and healing. We'll briefly talk about the different sutures that I use and the needles that we use. We're going to talk about tying knots and certain suture techniques that we have. I'm going to do a short little video on an orange that you can use to practice. Maybe not tonight, depending on where you are, but certainly in your free time in your office to get really proficient and efficient. We'll talk a little bit about membranes. I think membranes are a very important part of grafting. If we're using an allograft material, we must protect that allograft, which is bone from another human source. We must protect that graft from invagination of epithelium. And so we use a long-term resorbable membrane, at least that's what I use, that will prevent epithelium from growing into the site. Many of you out here probably have heard grafting procedures or lectures before, and have you used certain products and done the techniques, but when you went back to evaluate the site, you found it was mush. And we can't tolerate that. We must create predictability. Patients are paying you money, so let's learn the techniques in the short time we have together so that we can grow bone predictably. We're not going to hope or guess, and we'll be able to objectively, through our digital radiographs, determine when we have bone integration for potential dental implants in the future. And we'll talk a little bit about extractions and other grafting techniques that I use in preparation for our implants. Now, in my practice, extractions and grafting is a preliminary step towards what is the most financially rewarding procedure you can do in your practice, and that's the surgical placement of implants, fabrication of abutment, and the final restoration. We know when we lose teeth, your patients are losing teeth probably every day in your practices. We know physiologically bone's going to change, right? We know it's going to shrink down, it's going to shrink up and in, depending on the arch. Our denture patients often lose so much bone that they get paresthesia or dehiscence of the mandibular foramen or the mental foramen, and our faces collapse. So placing a graft material is an integral part of the extraction technique today, especially if patients are inclined to have dental implants even in the future. If we don't graft, we don't know how the site is going to heal. We've all seen the concavity in the aesthetic zone in the facial area. We've all seen the horseshoe saddle, the horse's saddle in the posterior mandible. We've all seen our sinuses being so large that placing an implant is very prohibitive or requires a much more invasive surgical placement of bone graft, which is much more expensive. So doctors, educate and instruct your patients on why this is an important part of their dental health and dental care. If we graft at the time of extraction, we can minimize bone loss. We can support the soft tissue, and that's what we'll demonstrate today. We can help minimize periodontal pathology. And we certainly, with the techniques I'm going to show you in our short time together, provide adequate site for implants in a short 3 to 4 months. And we can objectively determine this radiographically. If the patients refuse our grafting procedures following following extraction. We will get invagination of epithelium into the socket site. We are going to lose vertical and horizontal bone height and width. And the literature will say that we will get 30 to 60% bone loss in a 3-year period. If you're going to take one photograph of any slide, this is the one, because this is educating your patients on why it's imperative that they have grafting done so that they don't need a more invasive, expensive surgical procedure in the future. Failures of our grafts occur for a number of reasons. Number one, our suturing techniques are improper and the wound opens, becomes infected. If we're using an allograft material and we place a membrane, that membrane must be passively placed at least 2 millimeters beyond any facial or a lingual defect. That's critical. And that membrane must remain intact for at least 6 weeks to be predictable. Now, many of us know that. We place our membranes, but maybe we force it. We tug, we push, we rip, we tear, we suture over the top of it. And when the sutures are removed or the membrane dislodges and comes out before 6 weeks, the case becomes unpredictable, and that's no longer acceptable. And obviously infection can, failure to decontaminate the socket site. You've heard me, for those of you who heard me before, it's important that we curette, eliminate any granulation tissue, eliminate any purple blood from the site. Red blood is good. So very typical situation. We're kind of carrying through where we ended up in part one. We have a horizontal fracture at the post line. Don't we all love posts as dentists, a necessary evil? And I don't know about you out there, but I am seeing more teeth, more root canal treated teeth fracturing than ever any time in my career. But we have a horizontal fracture resulting in a significant periapical abscess, and this tooth is going to be extracted. So how do we do this? We're going to evaluate the site. And you've heard me, I'm not going to talk about this a lot, but I think it's important that we use techniques that are simple to use. Again, time is very important to me in my practice. Time is equal to dollars created in a daily basis. So I really love the physics forcep. It was created by Dr. Richard Golden here in Detroit. Golden Dent occurred at the end. I'm sure we'll have some type of special. It's a series of 4 instruments: upper right, upper anterior, upper left, and a lower universal. The little green caps on there are silicone bumpers, we call them, that are just soft. The instrument has 2 components. The shovel-shaped edge will engage the lingual or palatal aspect of a tooth 1 to 3 millimeters subgingival. You must have a purchase point on that. The bumper is not the working end of the instrument. Rather, it will be placed as high up or as far down below the vestibule as possible. It is not holding the facial plate. It is not the working end of the instrument. Rather, it is simply acting as a fulcrum point, a center of rotation, which allows this lever to remove the tooth or luxate the tooth up and out of the socket in a matter of about a minute. Now, what's holding a tooth in position? The periodontal ligament. And this instrument will create tension on the lingual or palatal aspect without squeezing the handles. There's no hand pressure, no forearm, no bicep, no shoulder pressure whatsoever. Rather, it's simply a rotational movement creating constant tension on the lingual or palatal aspect of a tooth. And the forces will be along the curved axis of this uniquely shaped instrument. And within a very short amount of time, the body will release an enzyme, which will break down the periodontal ligament, and the tooth will elevate up and out of the socket. Again, the 2 parts of the instrument are the beak and the bumper, which is simply a fulcrum. So you can see I'm simply placing the beak on the lingual aspect, 1 to 3 millimeters subgingival, placing the bumper as high up the vestibule as possible, and I'm simply rotating my wrist towards the corner of the eye, and within a matter of seconds or a minute, the tooth will dislodge up and out. Now, it's not intended to remove the tooth in total, rather it's intended to luxate it up and out and without damaging the facial plate. And again, you can see I'm not squeezing the handle. Actually, my index finger is doing all the work in this situation. We then use a tooth delivery instrument or a bird beak forcep to remove the tooth in total. And you can see we remove the tooth relatively atraumatically or minimally traumatically. The patients really do not experience discomfort, assuming you have anesthesia, because we're not squeezing the instrument. We're not putting a lot of tension or force on that instrument. It's atraumatic or minimally traumatic to the available hard tissue. Bone is gold to me, to all of us. We want to maintain as much bone as we possibly can in every situation. Maintaining the facial plate makes this procedure so much easier. And finally, atraumatically or minimally traumatic to my body, my hands, my arms. If you have any dexterity issues with your hands, this is a wonderful instrument to use. This is called the Osteogen plug from Golden Dent, and it is a calcium apatite material. It's a synthetic material in a bovine Achilles tendon matrix. This is not a collagen plug. This is truly a graft material that's been used for over 35 years. A lot of research. It is a material of the same consistency as our natural bone. It is very inexpensive to use and simple to place. If we have a socket with all walls intact, a socket, you were simply taking this instrument, this material, and placing it slowly into the curetted socket. It is absorbing blood. It has some resistance to it. And I will simply take a plugger and plug it into the site at the crest or slightly above the crest. It's a combination of bioactive crystal particulate in a purified collagen matrix. It makes socket preservation easy and affordable to your patients because really this is a very fast, efficient technique. So you're going to charge out for the extraction and you're going to charge out for this graft, but you're going to be happily surprised at the cost of this material. We know allograft is expensive. $100, $110, $120 1 cc vial. We know that we must protect allograft with a membrane, a high quality membrane, which we know costs another $100 or so. This material is $40 or $50 per site. And we don't need a membrane. The consistency of the Achilles, bovine Achilles tendon matrix means that two things will occur to the epithelium. It can either grow over the top of it or it can try to fight through this collagen barrier. And it's always going to follow the path of least resistance. So you don't need a membrane with this. And this is how it's packaged. So we're taking it to site. Again, it's a grafted collagen combined. It don't need a membrane with it. It is truly a graft, prevents migration of connective tissue through a physical and chemical barrier. And as I said, the physical barriers when you're condensing the material firmly into the socket, and the epithelial cells will choose to grow over the top of it and follow the path of least resistance. So I'm putting this membrane to the crest or slightly above the crest. Now, I have to hold that material into position. And so here I simply place two interrupted sutures. We're going to demonstrate that in just a few moments. Two simple interrupted sutures that will hold the material in place. Now, directions to the patient. No heavy spitting, no straws. Stay away from crunchy foods like nacho chips, potato chips. Smoking can be a problem in certain situations. I like to see my patients in a week to remove these sutures and to evaluate the healing. Now remember, I'm preparing this site for a future implant. epithelium will grow a 0.5 millimeter to 1 millimeter a day. So in the 7 days between the surgery and when I see the patient next, if I'm correct, this area, this surgical area should be nearly completely closed over with epithelium, which will grow over the top of it. Immediately post-operative, you can see the material does have some radiolucency to it. But look what happens after a very short 4 months radiographically. I think we all agree we see a change in that site. Physiologically, the integration will occur from the apex of the socket to the crest. And this is very, very predictable bone grafting procedure, which allowed me to place an implant. After 4 months, I allowed the implant to integrate for another 4 months, and then we can restore the tooth. In this situation, you can see I have what we call a healing abutment, or a tall screw that penetrates through the soft tissue. That means that I got really good torque in this grafted site. After it heals, we take an impression, and the laboratory is able to fabricate, in this situation, a custom abutment and a nice zirconia crown, which has emergence profile. Doctors out there, this is routine dentistry for you today. We can teach you how to predictably place dental implants, maintain the soft tissue, and provide your patients with high quality dentistry, which is financially rewarding to you. So let's look at a quick video here where we're going to remove some teeth. And here I'm taking a peritone from Golden Dent. You can see the teeth are very, very infected. They're bleeding profusely. And I'm going to take the physics forcep as I just demonstrated, placing the beak 1 to 3 millimeters subgingival on the palatal aspect. The bumper as high up the vestibule as possible. And doctors, look, I'm not squeezing the instrument, rather I'm rotating towards the corner of her left eye. Just putting constant tension on the lingual aspect. The bumper is just acting as a fulcrum point. And in real time, just taking my time on this cuspid tooth. And the tooth will pop. You're not going to hear it pop. You're going to see it disengage. The instrument's not intended to remove the tooth in total. Here I'm taking my tooth delivery instrument and simply, the crown came off first. I'm going back to the root and removing this tooth in total in a matter of seconds. Now, suturing that site is very important. We're going to graft and suture, and that's what we want to demonstrate in this program today. Another tooth, a molar tooth that's deemed non-restorable. We're going to go ahead and anesthetize, evaluate the anesthesia, take my physics forcep, place the beak on the lingual aspect. The bumper is high up the vestibule, and I'm simply using my finger to rotate this tooth up and out of the socket, taking my tooth delivery instrument and removing this tooth. Now, I challenge you, many of you are proficient at removing teeth, and some of you have, it's more challenging. I know a lot of roots are broken, and I know we spend a lot of time taking teeth out where it's challenging. Taking teeth out can be challenging. And you can see we took this tooth out, this molar tooth, with divergent roots out pretty efficiently. Many of us would have sectioned this tooth. You would have taken a burr and sectioned the palatal root and the mesial facial and distal facial and taken them out separately. I always take a radiograph after I take a tooth out. I want to make sure there's no spicules or roots fragments left. We are then going to curette efficiently, and I strongly recommend that you purchase a grafting kit. I know Golden Dent has an excellent one. You need sharp instruments to be able to do this efficiently. And here's their kit. And I'm sure Kurt will have some kind of special for this. I know it's not very expensive, and it's my favorite grafting kit. Very compact, and he has a lot of various instruments. We have curettes that are curated. We have Orban knives. We have spoons and pluggers. So this surgical kit, this grafting kit, is really an excellent tool to incorporate into your practice. I really like the serrated curette in this kit because it does allow me to create a bleeding site and remove any granulation tissue very effectively. And you can see the huge granulous mass that we were able to remove from that socket. We see the divergence, and we're going to go back to that Osteogen plug from Golden Dent. And you can see I just simply cut it with scissors to shape of the tooth that we removed. We go to the socket, and doctors, I think you can imagine this is not a time-consuming procedure, and very effective and very efficient. We're plugging it firmly to the crest of the ridge or slightly above it. Now we must protect it. Now suturing this is very important, and I like to teach this because I think most of us out there were trained to take our reverse cutting needle from facial to palatal. It makes sense. However, when we do that, and if we had a membrane on that crustal portion, it is very easy to take that reverse cutting needle and perforate through the membrane. Now, if we then remove the sutures, or your staff does, and they remove that membrane, what did I say earlier? The case becomes unpredictable. I don't know how well it's going to heal and whether or not epithelium is going to affect the healing properties of your graft. So what I recommend, and I'm very, very consistent with this, is when I suture, I will suture my reverse cutting needle from the crest to the facial aspect. Therefore, I am sliding on top of any membrane, or in this situation, the graft material. And there are many different sutures out there. You'll use your favorite. I use the PGA, polyglycolic acid, or Vicryl. Golden Dent has an excellent one. Some of these materials are very expensive. Golden Dent is very reasonable. It's resorbable, and it resorbs to water in 28 days. So I don't see a lot of inflammation, and it handles very well in my hands. I know we all have our favorite materials. I don't use silk in the practice. Silk does have a tendency to absorb bacteria and plaque, and it does result in some inflammation. Many of us out there use plain gut or chromic gut, which is fine. It's just not my favorite in the handling. All our needles in dentistry are reverse cutting needles, and I would suggest, I'm not a big inventory person and everything out there. I suggest that you purchase a 3/0 and a 4/0 thread, and I suggest that you purchase a 1/2 circle and a 3/8 circle reverse cutting needle. And this will allow you to do basically anything that I do in my practice as far as extractions, grafting, suturing, and eventually implant placement. Here's the Golden Dent sutures, the PGA, how it's packaged, and I'm sure Kurt will discuss this a little bit later. This is a great suture book that I really love. It's schematic, and it goes through basically all the different important suturing techniques that you need to know for extractions, a little bit of periodontal therapy, and definitely dental implants. Now, I suggest that you don't go to Amazon or Barnes & Noble, because I've seen it for like $1,000 on those sites. But if you go to Salvin Dental, Salvin Dental out of Charlotte, they may have purchased these books, and I think they charge $99 for this book. There may be others on the market, but I really, really like teaching with this book. So we took that reverse cutting needle after we had extracted and grafted the site, and I went from crest to facial. Now I'm simply reversing that needle and going crestal to palatal. And we just did 2 interrupted sutures that's holding that material in place. And again, epithelium is going to grow a 0.5 millimeter to 1 millimeter a day, very predictably. Now, it may take, when we see this patient in a week, it may not be completely closed over, and I will oftentimes say, hey, everything's looking really, really good. You're 80% healed. By the end of the weekend, you won't even know I did anything. So this is a very simple procedure. You can see on the facial aspect that I maintained attached gingiva, a band of attached gingiva on the facial aspect. So how do we do this? Let me just go through this. I'm gonna run through this a little bit quicker of the suturing techniques.
There are different types of techniques. These include an interrupted, which we will discuss. We'll talk about a modified interrupted. We'll do a continuous. Maybe we'll even do a continuous locking. We can do a continuous horizontal mattress, a vertical mattress, and a horizontal mattress. And I think through those 7 techniques, we've demonstrated just about every application that you will use in your practice. So here today, we're going to use our 3/8 circle reverse cutting needle with a 3/0 plain gut. And remember, we talked about earlier the sizes of the thread goes from 1/0 to 10/0, with 10/0 being the smallest. So in dentistry, most of the time, I will use either a 3/0 or a 4/0 suture. There are different types of suture material that we can discuss. First is silk. Silk is the most common. It's relatively inexpensive, and it ties a very, very nice knot. But remember that silk draws bacteria and needs to be removed in a short period of time because we will get some inflammation. Some of the polyester materials like PTFE, polytetrafluoroethylene, are braided, and they are lubricated to some extent, and these are non-resorbable. I guess we used to talk about Gore-Tex materials. They slide and they can untie sometimes, so it's a material that I don't use that much. Resorbable material, we're going to be using a resorbable here. Really, there's 2 basic categories: the plain gut, which unfortunately loses its strength after about 24 hours. And then chromic gut, which is treated with a chromium salt, will last up to 10 days. And I've mentioned in my lectures that I like to bring my patients back routinely, even if they have resorbable sutures, in 7 to 10 days to eliminate any inflammation, irritation, and just to check on the surgical site. What I use most often, and what you've seen in my lectures, are the synthetic materials, the PGA, polyglycolic acid materials. This is like Vicryl or Villet. These are hydrophobic. There's a slower rate of resorption from 3 weeks to 4 weeks. We get very, very mild tissue reaction, and they resist muscle pull. They also are very easy to use. They're a little more expensive than, say, the synthetic materials, than the polyester materials, or the resorbable plain gut or chromic gut. But that's what I use most often in my practice. So let's discuss different types of sutures. And what we'll do is you'll take your scalpel, and here I'm just using a disposable scalpel. And let's just take our work, be very careful with the sharp blade, and we will simply make a long incision here. Now, when you're making an incision in tissue, we want to make sure that we have a clean incision and try to make one pass. So you're going to go all the way to bone through the periosteum, and that allows us to make a clean incision without having to make multiple pass-throughs or multiple cuts. I mentioned in my lecture, we'd like to stay in attached gingiva. Even if we're doing vertical incisions, try not to go into the mucosal tissue. When we go into the mucosal tissue, we will create a lot of prostaglandin release, and the patients are very sore. Also, we lose control. We lose control of our relieved or our flap material. so it makes it a little bit more difficult to suture them closed. So we made an incision, and let's go ahead and let's practice on some of our techniques. So let's just do a simple suture. Now we have different types of suture holders. We can use a hemostat, which is in your kit, or just something fancier. But let's just do a simple interrupted to begin. In a simple interrupted, we call this the facial or buccal, and this is the lingual. We go from facial through the tissue onto the lingual or palatal. Can't be any simpler than that. We'll leave a little bit of a tail. And what we'd like to do is we'd like to loop twice. 1, 2, grab onto the end of the tail and pull taut. And then do the same thing, 1, 2, taut, and then once backwards, just one, grab the tail and lock it in. And then we take our scissors and simply cut. So we have an interrupted suture. Pretty basic, pretty simple, works very, very well. The second one we'd like to do is called a modified interrupted, where we'll go from facial through the incision site, not onto the lingual or palatal. Leave a little tail, and then simply reverse your needle, and then go from the lingual or palatal through the incision line, not onto the facial. And this will kind of pull the incision together in the same technique, 2, 2, 1 will give you a nice closure. This is referred to as a modified interrupted suture. And it's good to practice these techniques. They work very, very well. And then you can cut that. So that's called a modified interrupted. When we have a long incision, a continuous suture is often very, very helpful. So here we will do our same passage as if we were doing an interrupted, and we'll tie the knot as we did earlier. 2, 2, 1. And we'll simply cut the tail here. Leave the long part alone. And then we're simply kind of going back and forth here from facial to lingual or palatal. And then just keep passing it through as if you were sewing. I'm sure a lot of us still darn socks today. And this will give you a very, very simple suture to get closure. And if we want to tie the knot to finish the line, this will leave that a little bit taller, and simply same technique, 2, 2, 1. Of that suture. I don't use this type of continuous very often, but it will work very well and fits very quick. Let's move on to a continuous that I use more often, which is a continuous locking. Now let's go ahead and make another incision here. And this time I'm going to use an Orban knife. I'm not sure you have an Orban knife in your kit, but you saw me demonstrate it during the lecture. And instead of a scalpel blade, an Orban knife is very specially angled, very sharp blades. I love this instrument. It allows me to make a very nice controlled incision. And even if we were working around teeth, we can make a nice incision. You heard me in the lecture talk about an envelope flap, where we have like a number 10 envelope and we open it by blowing into it. So again, we can make a nice incision here. So let's do a continuous locking suture, one of my favorites when I have a very long span of reflection. So let's just look at the suture for a moment. As you take these gut sutures out of the package, they're kind of curly. So if you just hold on to it and kind of run your finger through it, you'll straighten it out. So let's do a continuous locking suture. So again, I'm starting with an interrupted, as we've done previously. And again, 2 forward, 2 forward, 1 back is my technique, and sutures just don't come loose when you follow that technique. So 2, 2, and 1 backwards. And then we'll simply cut the tail. Leave it 2 or 3 millimeters so that your staff is easy to see. Now, what we're going to do here is kind of interesting. I'll go kind of slow here. Is we're going to go facial to lingual or palatal again, as we've done earlier. We're going to space these a millimeter or 2 millimeters apart. Okay, now this is important. So we have the circle here, and we're going to go through the circle and pull it taut. And then we can continue that pattern. This is a nice suture, and I have a long span. Again, pull it through. Again, you have your circle. Bring it through. And I'll usually have a staff member kind of hold it for me taut so that the sutures stay taut. And let's just do one more. So suturing is very, very important. Now, when you're finished, this becomes your tail. The circle becomes your tail. And again, 2 forward. Two forward. 2 forward again. And 1 backwards. Very consistent. Get into the routine, and these knots will not come loose for you. And then we can simply cut both of them really effectively. That's called a continuous locking suture.
So you can see the techniques we use are fairly simple, doctors. An interrupted suture is very effective. It gives you good control. It is a little time consuming. And my suggestion is that we don't go facial to palatal, rather we go from crest to facial, turn the needle around, crest to palatal or lingual, and 2 forward, we'll tie the knot. 2 forward again, we'll set that knot and push the entire knot down into the incision line, and 1 backwards will lock it into place. The other one that I use a lot is the mattress suture that I showed you at the very end. And again, practicing on an orange or lemon is really, really helpful. Around dental implants, we oftentimes will have, we want to create or maintain a band of attached gingiva on the facial aspect of our implants. And in those situations, and I demonstrated, I think that in part one pretty effectively, is using the healing abutment as a tooth and just repositioning tissue, attached tissue that may have been on the crest towards the facial aspect of our dental implants. So using your suturing techniques properly, using the proper material, the proper needle design, respecting the soft tissue, understanding and realizing the type of tissue that you have in certain areas is very, very important. And again, these are the schematics in the book that I recommended, and it's very, very clear and very easy to practice with. The continuous that we showed you at the very end is a very fast, efficient way of suturing. Oftentimes I will do a full arch with a continuous suture, and the patients will ask me, how many stitches you put in? And I'll say, well, one. But we kind of laugh about that. So be very conscious of the different designs and types of suturing techniques that are available to you. We need to master these. And once you master them, you're going to have very, very good control of every situation. So let's go through a case, our last case, and then Lauren, I think, didn't mention that if you want to type in any questions that you have, I'd be happy to sit with you and do that. I think we can all agree that we have a non-restorable tooth here, abutment tooth for a conventional bridge, that has created a significant periodontal defect. So we're going to take that tooth out. I sectioned the bridge or took the bridge off, and you can see the incredible bone defect or hard tissue defect that was created, not from the extraction itself, but from the damage and trauma created from this vertical fracture of the tooth. We are evaluating that site, eliminating granulation tissue. And what's very interesting there, if you look at the very center of this case, you can see hard tissue, but you can actually see the Schneiderian membrane. And if the patient breathes, it kind of moves in and out, but it's not perforated whatsoever. It's intact. So in this situation, it's not a case to panic about. We can grow bone very predictably, and Golden Dent will help you with the tools, the equipment, and all the grafting materials and sutures that you will need to do exactly what we're doing here. So what I did was I took that calcium apatite osteogen material from Golden Dent, and I simply very, very carefully, very gingerly placed it into that defect where the Schneiderian membrane was. And I'm actually elevating that Schneiderian membrane. And I can actually elevate it, the literature will say, about 6 millimeters without perforating it. So I'm very, very gently packing my material, and that's basically going to create my new floor in that site. Now, we also have a tremendous defect in that area, and my suggestion is if a defect is more than 5 millimeters, then I will use an allograft material and a long-term membrane. And here I used allograft material, again from Golden Dent, and I wetted it with sterile water. Do not use anesthetic, please. Anesthetic is going to decrease the pH, and it's going to affect the healing, the turnover of that allograft material to bone. So do not use anesthesia as you're wetting the material. And we have Gold Os particulate, again, a very high quality material that is relatively inexpensive compared to some of the competitive materials out there. And I packed that entire defect with my 250 to 1000 micron crystals, packing it firmly, not crushing. Now, as I mentioned earlier, whenever you use a allograft material, we must protect the allograft from invagination of epithelium. So here I took a long-acting membrane. It's a 3 to 4 month membrane, collagen membrane, that I will passively place at least 2 millimeters beyond the defect. So I'm on solid bone. You must feel comfortable reflecting tissue comfortably. And as I mentioned earlier, try not to make vertical incisions into mucosa, and your patients are going to be amazed at the limited amount of discomfort they will have as long as we're not incising into mucosal tissue. Here we're using EpiGuide from Curasan that's available through Kurt at Golden Dent. This is a synthetic material. There's some outstanding collagen long-term resorbable membranes also. And I passively placed it beyond the defect on the facial and passively onto the palatal. Now let's review surgical techniques. Rather than going facial to palatal, which potentially could engage the membrane, which could cause it to come out when I remove the sutures. Rather, I'm going from crest to facial. I'm going to reverse the needle and go crest to palatal. And I'm going to do a simple suturing technique, 2 forward, creating a knot, 2 forward again, setting the knot, and 1 backwards. That knot will not come loose on you. Now, whether or not you do interrupted here or you do a continuous will be up to you and your comfort zone. Here we did a CBC immediately following graft, and you can see the material place. It was a huge defect in that site. 1 week post-op, this is what you expect. Epithelium will grow 0.5 millimeter to 1 millimeter a day. I will remove these sutures. I'm not concerned that we see exposure there. That's the membrane. It did not dislodge. We have attached gingiva on the facial aspect of my implants, 2 very important critical parts. And epithelium will grow 0.5 millimeter to 1 millimeter a day, and that will close over. Excuse me, I'm so sorry. That will close over in a matter of 2 or 3 days, and then the patient won't realize. 4 months post-op, we're evaluating the site radiographically. We see that we are getting bone turnover, and again, talking in concentric circles, the integration will occur from the apex towards the crest. And here's our surgical site 4 months post-operatively. Our 4-month post-operative CBCT illustrates that we now have a viable site for implant placement. Now, it's going to take about a year for bone to mature completely, and I'm not concerned that I could complete maturity of bone. Rather, I need more integration in the apical 2 millimeters where I get my initial stability with my implants. And again, I'm going to allow another 4 months for integration to occur anyways. Be conscious of the mucogingival line. I'm going to remake an incision here to show you what was created in a 4-month period, doctor. This is in your wheelhouse. This is a procedure that you are certainly capable of doing, following the techniques that we demonstrated here. We have viable bone to place dental implants. We're going to do a core sample. We're going to make our osteotomy, starting with a small burr to a larger burr. Again, this is not necessarily an implant training, but we're going to widen the osteotomy, widen the osteotomy, widen the osteotomy, and place our dental implant very efficiently, effectively to the crest of the ridge. I'm going to place my second implant. Now you can harvest this viable bone. This bone is turning over. It's autogenous bone at this point, a great percentage is. And with any autogenous bone, you don't need to use a membrane. So use this bone on your burrs to repair any small defects or discrepancies. I'm going to place my second implant to the crest and evaluate it with our CBCT analysis, and using my suturing techniques again, tying a knot. And here I'm doing a continuous. So I tied my first interrupted, I came through, went through the rabbit ears, and went through again, went through the rabbit ears, and this now becomes a suturing technique that really takes minutes. Started with an interrupted with a knot, again, go through the tissue, then go through the rabbit ears, and it will continuously close the site very predictably, completely, in a very short amount of time. Evaluating not only the implant, the surgical site, the attached gingiva, and eventually you'll be able to restore this. So doctors, what I wanted to leave you with was a site that is you're able to restore completely. Again, very challenging situations, a lateral incisor with a tremendous defect, using my physics forcep to remove the tooth atraumatically, evaluating the site. Now, doctors, I have a facial defect. We can teach you to grow a facial wall 100% of the time. We're taking my Orban knife, I'm evaluating the defect, I'm making my osteotomy, placing my implants. I do not have a facial wall on my implant. I have stability, but I do not have a facial wall. Putting a cover screw, imperative with an allograft material from Golden Dent, Gold Os. Take your membrane, place it passively beyond the defect. I'm going ahead and using my allograft material, filling that void, passively placing that membrane and suturing. You can see I don't have primary closure here. I'm respecting attached gingiva. That epithelium could grow 0.5 millimeter to 1 millimeter a day. The defect will be corrected, and after 4 months, I'm able to take an impression. I have periodontal health, a custom abutment, and a final crown that has some type of emergence profile in it. Lauren, it's 9:02. I apologize. I went 2 minutes long, but you talked too much in my introduction. If you have any questions, I'd be happy to sit and to take them.
Yeah. I had to trim your resume down a little bit just to squeeze it in. We are going to get to the questions in a few minutes. What I want to do is flip the screen over to Kurt Lawler from Golden Dental, who's going to talk about some of the specials they have this evening, as well as some educational opportunities. For those of you who showed up a few minutes late, as a reminder, you probably didn't hear me do my spiel, the webinar is recorded. Golden Dent will send out a link to that sometime in the next few days. And if you've made it this far and you didn't just log on 10 minutes ago, you will be sent CE certificates. That usually takes about a week or so check your inbox sometime next week. You have to have been on for the bulk of the webinar. AGD PACE has certain requirements, so like if you showed up 25, 30 minutes late, they're just not going to be able to provide the CE. But keep an eye on your inbox for that sometime next week as well. So Kurt, I'm going to turn it over to you.
All right, thank you, Lauren. My name is Kurt Lawler. I'm with Golden Dent here, also based in Detroit. If you're not familiar with Golden Dent, we're a third generational dental family business here. We operate under the principle, starting with the physics forceps as our first product, of simple, predictable, and unconventional dental products. And we've kind of built upon that as we've continued to grow over the years and looking at for unique products that clinically work. As mentioned, this is the YouTube page. If you do want to go back and watch the first part of the webinar on membranes and suturing, you can find that on our YouTube page. I think there's a link on our website, otherwise you can just search for Golden Dent on YouTube, and this is just a screenshot of our page. If you subscribe, you'll get our videos we post on a pretty regular basis. Everything obviously on this page is free, and it's a good clinical content. So this is the discount code. As you know, if you've joined our past webinars, we provide a discount code just to reward you for your time of joining us for an hour and a half on a Tuesday evening. And the code is TW TW15 or TW15, and that'll give you 15% off anything on our website. So if you saw the sutures, or maybe you wanted to try our allograft or some of the membranes, this gives you an opportunity to do that and save a little bit of money. golden-dent.com is our website. Otherwise, you can obviously give us a call in the office, and our staff will be more than happy to help you out. So we do these deals for 24 hours. We do pretty good discounts here at 15%. And so we do them just for a quick 24 hours. So it's good through February 1st, tomorrow. So I just wanted to mention a little bit more background about our business. So extractions and grafting is kind of what started it for us. So we have our instruments, our grafting materials, sutures, and allograft materials. However, we've expanded on to, we have a full endo line. If you're not familiar or haven't been to our website in a while, we have endo files, some great endo motors, obturation systems, and we have the full Woodpecker brand of endo products and all of the other endo products that they have through Woodpecker. So the other aspect we have is our restorative line. So we have our sectional matrix system and a good curing light. So that's some of the restorative products that we have. But everything started here with extraction. So we're sort of your one-stop shop for atraumatic extractions and grafting. And we have everything you really need to do some of the cases that were displayed this evening by Dr. Kosinski. Physics forceps, this was shown, and I've talked about this many times, so I'm not going to really mention this again, but this is our atraumatic extraction system. We also do have the conventional type instruments like your 150 or 151 or ASH. We were asked to make this product by some of our customers that were looking for some conventional instruments, because obviously, physics forceps is not for every case. So this is a good alternative to, some of your more conventional type extractions. For a pre-step for the extractions, we have an instrument that we like called the wedge. Obviously, you can use a luxator or any type of elevator. I think the one in the bottom right there is the bayonet, which was shown by Dr. Kosinski this evening in some of the cases. He likes that instrument to use prior to the physics forceps for the extractions. This is our degranulation kit. So we showed the manual curetting of the socket site. And if you really can't, I guess, manually curette the socket site, there's a good degranulation burr kit that we have here. This has your bone leveling burrs, your tissue and degranulation burrs, and a nice cutting burr. We had this made. It's just it's all the instruments you need for extractions and grafting in one little burr block here. This is the serrated curette we showed. This is the graft kit, so I'm not going to mention that again. Osteogen plugs. This has really been a great product. We went over this in quite a bit of detail this evening. If you haven't used this product before, I suggest the large size, which is the 20 by 10 size. That's the most popular. They do have a slim and an extra large, which they're not as popular, and you can obviously always cut the product itself to shape. This is our allograft. So we do have the mineralized cortical cancellous mix. We have it in the 250 to 1000 microns, which is the 50-50 cortical cancellous mix in various different sizes. If you're using another allograft currently, we obviously would love to have your business. We think our pricing is fair and it's a quality product. These are the two membranes we've had for a long time. The EpiGuide, the one on the left there with the star, is probably our most popular. It's a fully synthetic, long-lasting membrane. And then we also have the Collagen, which is also long-lasting, a little bit more challenging maybe for handling perspective. The EpiGuide is going to be probably our favorite membrane that I would recommend if you haven't tried either one of these. Sutures, we obviously have the PGA, our golden dent sutures, and the black silk and chroma gut. Again, these were mentioned, so I'm not going to spend much time on that. And then lastly, so we can get into questions, I'll just mention a lot of doctors are already familiar that we do these hands-on programs. If you're looking for some live patient experience, which is really quite unique, you get to do all your own surgeries and extractions and grafting on live patients. We have 3 live patient type programs, which are called AMP1, AMP2, and AMP3. They get a little bit more advanced as you go up the numbering system there. So AMP1 is just simply an extraction class. And then you'll be able to place some Osteogen plugs and get familiar with that type of procedure. And then AMP2 is a continuation of AMP1, where we'll do more extractions, but then we'll allow you to graft the site, place membranes, do the suturing, and get into a little bit more advanced cases. And then AMP3, we try to focus more on like full arches. So it's going to allow you to set the foundation for dental implants or an immediate denture, just a little bit more of an advanced class. AmplifyDental.com is where you can learn about all our classes. This is kind of last minute. I think this one's about full. I think we have 21 doctors for February coming up here in a couple weeks, but I guess if you wanted to do something a little bit last minute, I think we can take a couple more docs maybe, and then our next one's not again until April 21st and 22nd. And that's it. I'll leave this on the screen, turn it back over to Lauren, and I appreciate everybody's time this evening, and we'll get through the questions that you submitted on the webinar this evening. Thank you, everybody.
Thank you, Kurt. Tim, you ready?
Absolutely.
One thing I will always tell people is that with this webinar, as with most of our webinars with Dr. Kosinski, we typically have more questions than we have time to answer them. I want to be respectful of people's time, so we are going to be finishing up at 1:30. But let's try to get to as many as we can. So, Tim, you showed a lot of cases with ridge, with socket preservation. Are there any techniques or systems out there that can really predictably improve on horizontal ridge augmentation?
You know, I don't really teach that, Lauren, in the courses, because that becomes much more challenging and less predictable. When we have a socket, all 4 walls are intact, using an Osteogen plug is ideal. It's brainless to me because it's inexpensive, and it's simple and it's predictable. I've done a lot of histology. We can teach how to grow a facial wall predictably, as I showed in the very last case, very, very quickly and briefly. Trying to get vertical height with and significant horizontal width really requires an autogenous graft, a block graft, which is involved, meaning taking bone from the symphysis, from the ramus. We do have synthetic blocks using screws. Obviously, we didn't demonstrate that here today, but there are materials and methods to do it. It's just beyond the scope of what we're teaching here today.
Sure. So are you typically doing immediate implants when you do an extraction, or does it depend on the socket?
If we have purulence in a socket site, I will curette the site, get rid of granulation, have red blood, and I will graft the site. The body will heal, but I will not immediately place an implant in a situation like that. And I use the analogy, Lauren, of a hangnail. If you ever had a hangnail, you're miserable, it hurts so bad. You're at Disneyland, you can't even walk. You go back to the hotel or your house and you soak your foot, you trim the nail, in 5 minutes you forgot that you even had that agonizing discomfort. The body's an amazing thing, it will heal. If we have a clean socket, meaning no purulence, or we're able to remove the granulation in total predictably, I love doing immediate implants. However, remember that when we take a tooth out, the socket itself is shaped like an egg and our implant is round. So often our implant, we have a void there, and I will graft a la caulking the site. And again, and I said it twice in the lecture, our initial stability with our implants is in the apical 2 millimeters anyways. So as long as I get initial stability, we can use a graft material. Now, I will oftentimes extract the tooth and fill that socket with an Osteogen plug, and the implant will thread beautifully into that material and push it onto the surface, filling the void onto the surface of the hard tissue, between the hard tissue and the implant. Allograft material, because of the various shapes, Kurt said, the sizes are 250 to 1,000 microns and they're irregular in shape. Sometimes it's more challenging to thread into that graft, but it can be done. Yeah, I love doing immediate placement of implants, absolutely.
Okay. What about cleaning out the socket? Do you ever use something like a piezo? Do you ever use Paradex? What do you typically recommend?
I never use Paradex, and you're a periodontist, Lauren. You may disagree. I've had this discussion before. Paradex inhibits bone formation, so I have the patients irrigate beforehand or in the past. Now we're using PerioScience, but rinse ahead of time to decrease the bacterial count. But I never have them irrigate into the socket. I never mix my graft with antibiotic. I'm sure that's going to be a question that we have too. I just never have done that, and I get great predictability. Sure, you can use it has to bleed. The site has to bleed. So you can use those burrs that Kurt from Golden Dent showed. You have to have a bleeding site, but you have to remove the granulation. I'll use a diode laser to kind of sterilize the site too.
Okay. Do you happen to know off the top of your head for the Osteogen plug, what's the ratio of bone particles to collagen in the plug?
I don't know.
Okay, I'm sure they can look it up. So is your standard suture removal at 1 week post-op?
Yeah, 7 to 10 days, depending on the patient. Now, remember, I use the PGA or Vicryl sutures, and those do resorb. They are resorbable sutures. But oftentimes, and I had a patient in today, my last patient, we had done full arch upper and lower and had done mattress sutures, and they were tight. And, he said, he did really well for like the third day, fourth day, it started to bother him. And what happens is the tissue wants to heal and the sutures try to inhibit it. And so it can be a little irritating to the patient. So I just learned after so many years of practice, just bring the patient back. I can see their healing, see how well they're maintaining the site, see how they're cleaning. And it just gives me a little comfort zone. And the patients, they're investing a lot in their future. And Lauren, I want predictability. I want to be able to tell my patients, I'm going to do this procedure. You're going to be charged so much, but I know it's going to work. I don't hope that it's going to work. I don't pray that it's going to work. I know that my procedures are going to work.
Right. What about, has anyone ever tried using a collagen plug for, say, something like an oral antral opening, communication there?
Absolutely. Yeah, and I kind of showed that a little bit where the Schneiderian membrane was intact, but you can definitely use it. Again, you got to be very careful. There's sheets, there's plugs. Sometimes I'll even put a resorbable membrane first and then do my Osteogen. Osteogen is a very special product, and it's basically turns over like natural bone does. So it's very, very unique. The literature is really pretty incredible with this material. For those who are out there who want to be more get more scientific data, it really, there's a lot of science behind it, and it's a very unique graft material.
Okay. What's your preferred?
Lauren, I just want to mention too, I have, if anybody wants to call our office this week, there's the one thing I want to mention about the plug is, they were kind of the first to do that. And I've seen more and more plugs on the market, and there's been a lot of research on it. But, they're just not the same. And I think, this plug really holds its structure, and a lot of the other plugs that are on the market that people are advertising, I guess, as a bone plug, they really just aren't the same as the Osteogen plug. And we see, customers that maybe have tried another one in the past or thought it was cheaper or whatever, and they always come back. I really do believe it's the best plug, and we have kind of a comparison sheet of all the different brands out there and can go over the pros and cons. But I just wanted to mention that we've been selling this for a long time. We do believe it's the best graft plug on the market still.
Okay, and since I got you on the phone, are PTFE sutures something that you guys offer as well, Kurt?
No, we do not have those currently. So we just have we have a black silk, the PGA, and then a chroma cut right now. Those are the only ones that we offer.
Got it.
And the reason is our instructors and Tim and different instructors that we work with, or the evaluators, they just don't use them. So we try to have the products that our instructors like, and they teach in our classes, and they believe in.
Okay, thank you. Tim, what's your preferred needle holder? Do you like a Castro Viejo, needle nose, hemostats? What's your go-to?
Castro Viejo is great. I'll just use a suture forcep normally, not a hemostat normally. You know,
Okay.
after so many years, you kind of use what I tell my staff, give me what I need, not what I asked for. So
Okay. Do you like Proline sutures versus like a PGA suture?
I'm not sure what that is. So I use PGA almost exclusively.
Okay, yeah. James, if you want to maybe put a little follow up there, we can do that. Do you experience difficulties in obtaining primary closure if you do not release vertically into the mucosa? How do you manage those situations?
I don't care about primary closure.
Right.
The
So
epithelium will grow a 0.5 millimeter to 1 millimeter a day. If it's allograft, I have a membrane to go over the top with osteogen. I don't need primary closure. The band of attached gingiva is much more important to me.
okay. What about for the types of implants? You do like HA coated, blasted implant surface? Yeah. Again, what's your go-to for that?
Yeah, we've done pretty much everything over the years. Now, currently, I'm using the Han implant system from Glidewell, which I love, and Straumann. Those are the two implants we use. Nobody uses HA coated anymore.
Okay. The that last case you showed with the lateral incisor, did you put a temporary flipper or did you put a temp implant crown to respect and
It,
keep the papilla healthy?
it was a flipper. I'm not a big Lauren, and you know this from previous lectures. I'm not a big immediate load. I'm a big immediate placement, but I'm not a big immediate load person. You know, I've been doing it for 35 years, and I've seen my share of issues, especially in laterals. Laterals are probably the hardest teeth that we do, in my experience. So, you know, we'll use an Essex, we'll use, you know, an acid etch bridge, we'll use a flipper, we'll use a snap it, depending on the situation.
Okay. What about for a case where, for example, you know, you got a large buccal defect, you lost attached tissue. Can you modify your flap technique to maybe grab some more keratinized tissue from the palate? And would there be any reasons not to do something like that?
You know, that's a great, that's a whole nother lecture, but yeah, you know,
Great, we got part three all lined up now.
Yeah, number 3. Um, Attached gingiva is critical. And I like to say this, Lauren, and I know with your experience too, you know, implants are placed, crowns are placed, and the patient comes back and they go, you know, something's just not right. You know, when I brush, it bleeds. And what do we all do? We take a radiograph and the implant looks good, the bone looks good, the abutment looks good, the crown looks good, but we have to have a band of attached gingiva. If we can't get it at implant placement, we can get it on implant uncovering. And we had kind of covered that in part 1 of suturing. And so I didn't add it to this program, but we can certainly review that again, or those who want to see it. There's methods, you can do it secondarily. You can do it on uncovering to gain attached gingiva.
Okay. Um, for the physics forceps, what modifications would you typically need to make when you're dealing with an ankylosed tooth?
It won't work with an ankylosed tooth. It's intended to create tension, which that tension results in a physiologic reaction of the body to release an enzyme to melt the periodontal ligament. If there's no periodontal ligament, it won't work.
Okay. Can you repair periodontal pockets with the plug?
You know, that's a great question, and I don't want to mislead our audience here because I'm pretty specific in the techniques that I know that everybody listening to us today can do predictably in their practice tomorrow. When we're talking about larger defects or facial defects, my rule of thumb at this juncture is if a defect is more than 5 millimeters, I prefer to use an allograft and a membrane as opposed to the osteogen plug. But we are currently evaluating cases that you just described. But I don't want to promote that too much at this juncture in my hands, because I do like to do a lot of histology, and I want to make sure that what I'm saying is predictable for doctors. Sorry.
Okay. That's okay. What about any modifications to your extraction protocol if you know that the root tips have like, you know, deep recurrent decay, or, you know, you just know they're going to be breaking off down there?
You have to have a purchase point to have this instrument work. So if the tooth is broken, I will take a 557 long surgical burr and I will create a purchase point on the lingual or palatal aspect of a tooth and still use the physics forcep. Or I'll use the bayonet or the peritomes that Kurt demonstrated in his surgical kit. Taking teeth out is hard. It's not an easy thing to do.
No, I know. Listen, as a periodontist, usually when I was extracting teeth, they were flapping in the breeze. I had done everything I could to save them. So by the time I was ready to pull them out, they were 10-millimeter pockets and had one wall left. So yeah, I had it easy. For everyone else, it was not so easy. You mentioned, I guess that was during the video, when you talked, you said start at the crest instead of the facial. Can you just kind of go over what exactly you mean by that?
Yeah, so most of us were trained. We have a tooth. You'll take the reverse cutting needle and you would penetrate through the facial tissue and go through the center of the extraction site and go to the lingual or palatal and then tie your knot. That's how most of us were trained. The problem with that is oftentimes we will engage the membrane, and when we take the sutures out, we will remove the membrane. And as I said, that membrane must remain intact for at least 6 weeks for the case to be predictable. If it comes out before then the case is unpredictable, and I don't know if I'm going to grow bone predictably or not. So what I mentioned, my technique has been go from the socket site or the crest, the socket site or the grafted site, and take that reverse cutting needle and go from that socket or grafted site to the facial first. That way that reverse cutting needle is sliding over the top of the membrane or the top of the graft without engaging it, and you can actually see it. And then I would reverse that needle and go from, again, the grafted site or the socket site, reverse the needle and go from that area to the palatal or lingual, and then tie your knot. That way I can see the needle actually riding over the top of the graft or riding over the top of the membrane. And I know I never engage it.
Okay. How frequently are you using a membrane with the osteoplug, and are there contraindications that you would not do a bone graft, for example? You already mentioned, I think, one before about having a purulence or an active infection.
Again, I want to go back to, I want predictability. We spent an hour together, and I want the techniques to be used and to be predictable. The osteogen is a very special material. And again, if my defect is more than 5 millimeters, then I'll put a membrane on top of it. But I can use osteogen and a membrane, or osteogen and PRF. We'll draw blood and we'll do those things. So there's a lot of applications that we're currently using that I didn't really demonstrate today. I wanted to keep this things that I know are working basically every day in my practice.
Right. What about, do you have any experience with like titanium membranes? I know that they're, getting some press out there.
Again, and Lauren, you've been doing this a long time too. Why? I'm going to redirect the question. Why do we have so many different extraction tools, instruments? Why do we have so many different membranes? Because it's hard. Because what we do is hard, and we know, whether we want to admit it or not, we've had failures or incomplete healing. And what I tried to demonstrate today is if the membrane is passively placed at least 2 millimeters beyond any defect and passively placed onto the palatal or lingual, and that membrane remains intact for at least 6 weeks, we're going to grow bone. The reason we have screws and plates and titanium things in there, they're expensive, is because we're trying to get that membrane to stay in place. I know, because I was one, that we know we have a graft, we know we have to put a membrane, and we will try to tuck that membrane. We will take 25 minutes pushing and tugging and ripping and tearing and trying to get that membrane to stay in position, and then suture over the top of it, and then it comes out. So learn reflection techniques, learn the protocol. It's simple once you get it down. If you make an envelope reflection, meaning no vertical incisions in the mucosa, that reflection, that tissue goes right back where it's supposed to go. And it makes it very nice for you and the patient.
Yeah.
That's a great question. I like that.
Okay. For if someone has an implant with a healing abutment that gets dislodged, say when they're on vacation, for example, and the tissue starts to overfill that, do you have any concerns about the longevity of the implant and something like that?
No, none. Remember that we get initial stability or torque with our implant, but it gets weaker over time. So at about 8 days, 2 weeks, it's really at its weakest point. So if a healing abutment comes out at that time, don't go back in there and try to tighten it, because you will dislodge the implant and it will fail. Let the tissue grow over the top, and then you'll just have to laser it or remove that tissue over the top of the implant.
Okay. Have you ever considered, or are there situations where you would use like a PTFE membrane? I know certainly, people have always had concerns about, well, if you're not doing primary exposure and it's not, and it's resorbable, I mean, could that fail?
I don't use it. I can only tell you what I do in my practice. It's not right or wrong, good or bad. There's 100 ways to do what I do. I don't use a non-resorbable membrane at all in my practice, because our resorbable membranes are intended to last for 3 to 4 months. I need it to last 6 weeks. So our resorbable membranes are such high quality today that I don't use a non-resorbable membrane. And a non-resorbable membrane, you have to have primary closure, which creates a challenge for me for attached gingiva that we just talked about.
Right. At what point are you tacking the membrane?
Rarely, because if you reflect correctly, if we don't make incisions into mucosa, we don't have pain, we have control. And if I could have a 10 millimeter defect and I just have to reflect it 12 millimeters so that I can see the defect. You can't be lazy doing this. And as a periodontist, you know that. You can't be lazy. It's very precise. There's rules that have to be followed. And if the rules are followed, you will get outstanding results.
And is the membrane typically just staying on the buccal, or are there some situations where you would like be tucking it under the palate as well?
I always flip it over so that it stays passively. Yeah. It'll go over the ridge. Yes.
Got it. We actually made it through all the questions, and we're at the bottom of the hour, so good timing on both our parts.
Good at this, Lauren. You and I
will.
Really good at this.
I will turn it over to you to give us some closing comments, and then I'll close it out for the evening.
Well, you mentioned before we started you're going to be at the Southern California. I will be there this year. Is that in San Diego? I'll see you there. And
in LA. Well, yes,
LA?
CDA is always in LA.
Okay.
Anaheim, to be, if you want to be exact, but it's LA.
And I really appreciate you taking the time with me. I always enjoy you and the nice introduction. You always make me giggle. But hopefully this was helpful to our listeners today. And I know we had a huge group. I'm very proud of that. So thank you for all you do in education out there. Thank you.
Well, thank you. Of course, you're the one that drives it. They're not here to hear me. They're here to hear you. And thank you, as always. Any of you who have been on Dr. Kosinski's previous webinars know that, this is the guy. If you want to learn suturing, implants, surgical techniques, extractions, this is, you're at the right place. This is where you need to learn it. And certainly, I think Golden Dent probably has a lot of the previous webinars on their website or on their YouTube channel. If not, I can certainly get you them as well. Final reminder, I mentioned it twice already. The webinar is recorded. That recording should go out in a few days. The CE certificates will be sent to everyone who is on for the bulk of the webinar. You have to have been here for at least 70, 80% of the webinar. I don't think the Q&A session counts. It's just up for that first hour. But they will, Golden Dent will send that out as well with 1,200 plus people that were registered for the webinar. That can take about a week, perhaps a little bit longer. So check your inbox, sometime next week. Check your spam or junk folders. Sometimes it ends up there, but it will go out. We thank all of you for joining us. We know your time is valuable. We do these webinars on a regular basis, and all of you who are here this evening will certainly be sent invitations for upcoming webinars. So thank you all for joining us. Please stay safe and healthy out there, and we look forward to seeing you all on future webinars. Good night, everyone.
Good night.